During this presentation, we'll try to cover certain aspects, and I hope they'll be very useful for you guys. The biological agents, type of biological agents, mechanism of actions, and then we'll allude into the infection risk, specifically tuberculosis, both active and latent tuberculosis. And then we will go and talk a little bit on the screening methodologies for patients who are supposed to be receiving biological agents. So the best start would be what biological agents are. Dr. Peter, in his presentation, he actually sort of introduces the topic by introducing a new therapy for a cholesterol. And this is a new era, the era of personalized therapy, the era of target treatment. In the coming few years, we will be specifically targeting certain diseases with certain treatments. So biological agents or targeted therapies involve the use of living organisms, substances derived from living organisms, or laboratory-produced versions of such substances to treat disease. The agents used for biological therapy are designed to specifically target a biological phenomena, gene, protein, or a group of genes or proteins thought to be involved in the disease process. This is actually the future for treatment of diseases. Now, there are so many indications, and you've heard one of them today on the management of cholesterol. There are newer target therapies for so many spectrum of illnesses, but inflammatory diseases is what we're going to be concentrating on today, or immune-mediated inflammatory conditions, rheumatoid arthritis, ankylosing spondylitis. Even asthma, for example, is among those which are thought to be immune-related, and some treatment of biological therapy is being developed for treatment of refractory asthmas. Now, when we talk about biological therapies for immune-mediated inflammatory disease, there are two sets. There are the cell surface soluble receptor antagonist and the monoclonal antibodies to cytokines or their receptors. So basically, you are targeting those inflammations or inflammatory processes that are responsible for the disease pathophysiology. Now, just one slide to try to get the names, to make you more familiar with the names. So when we say a mAb, we always refer to a monoclonal antibodies. When we say a MOMAB, it indicates a murine antibodies, which basically is derived from non-humans. When we use the ZMAB, it indicates a chimeric monoclonal antibodies, which basically is an antibody composed of a human component plus a non-human component. When we use the word ZUMAB, it indicates a total human antibody. So this will make the terminologies sort of more friendly, because sometimes you sort of have difficulties remembering the names and all of this stuff. For example, if you see, or if you use infliximab, then you know that this is a chimeric monoclonal antibodies derived partially from human and partly from animals. If you say adalimumab, this is actually the Humira is mainly humanized versions of monoclonal antibodies. Now, the mechanism of actions, there are so many mechanisms, and this is really a developing area. But for simplification purposes and for the sake of this presentation, there are three main areas or domains: interference with the cytokine functions or production, inhibition of the second signals required for T cell activations. You know, T cell is a very important cell responsible for a lot of immune-mediated processes. And the third one is to actually try to go and deplete B cells, which sometimes is used for cancer treatment. Now, I'll give you a few examples, some of these medications that you are familiar with. If you have treatment to target a cytokine called the tumor necrosis factor, these are some of the examples, infliximab. If you have treatment, or you can have treatment that targets the interleukin 1, interleukin 6, interleukin 17, 12, or the B cell depletion inhibition like the rituximab, the famous rituximab used in a lot of inflammatory conditions. One slide to try to emphasize the link between TB and these immunoglobulins or these cytokines. In order for you to protect yourself against tuberculosis, there is a lot of interactions. A lot of these cytokines are needed. But one important cytokine is the tumor necrosis factor. And one of the important jobs of the tumor necrosis factor is to try to maintain the integrity of the granuloma. So presence of tumor necrosis factor actually maintains the disease contained. If you lose that, if you inhibit that, you will end up basically disseminating whatever you have. And this is the basis. It's important for you to remember this when we talk later on upon why anti-tumor or tumor necrosis factor drugs are bad for tuberculosis reactivation. There is a long list of cytokines. All of them do work in tuberculosis immunity. Each one of them will have some role. But by far, tumor necrosis factor alpha is one of the major components to contain tuberculosis. Now, these are some of the examples of some of the monoclonal antibodies that are developed blocking different types of these cytokines. But we are really going to concentrate a lot about tumor necrosis factors because they have, as you're going to see later on, they have the highest risk for TB reactivation if being blocked. What is common about all biological agents for the indications just mentioned is that they all have some potential increasing risk of infections of some sort of another. The risk and type of infection is variable according to the mechanism and the agent used. The time of infection is also variable according to the agent used. So not every biological agent is similar. They are not the same. And the rest of the presentation basically is going to try to risk stratify the tuberculosis potentials, reactivations potential based on these factors. Now we have the British Biological Registry and then the US reported infection associated with biological drugs. Both of them are showing increased risk with these biological agents. And it's quite interesting to see that it's not only tuberculosis which is affected by this blocker. Listeria, Salmonella, Legionella, non-tuberculous mycobacteriums, they have one thing in common, by the way, they are all intracellular pathogens. Other fungal infections are also a risk. So it is not only tuberculosis that need to be addressed. The rest are also important. There's one slide at the end of the presentation that we're going to talk about that. But tuberculosis is the title of this presentation, so we're going to allude into more information. So as we said earlier, we're going to go through the risk stratification of TB infections and reactivations and biologics. One important risk stratification is the primary, for the primary TB or LTBI reactivation is the patient himself or his comorbidities. And you are all familiar with this graph or with this table that is present in everywhere to classify the patients into high-risk group, for example, HIV patients, transplantation patients, silicosis patients, patients on hemodialysis, and then into a moderate risk group, slightly increased risk, and low risk, and very low risk. The second risk stratification parameter is the biological agent itself. And as we said earlier, tumor necrosis factors are the biggest group. And the thought is that tumor necrosis factors do interfere with the granuloma maintenance. So it basically, tumor necrosis factor is critical in the formation of granuloma, and they are produced by macrophages, and excessive and prolonged inhibition of TNF signals lead to exacerbation of TB by basically disseminating the infections in the granuloma. Now, this is a pictures of a patient being treated with infliximab compared to a patient where he has a granuloma, well maintained, and then you lose basically the granuloma formations when you have infliximab on board. But you have to remember that although they are all tumor or still among the tumor necrosis factors inhibitors, they are not all the same. They differ as well. So some of them do more inhibitions on the anti-TB specific cells compared to others. For example, infliximab compared to adalimumab will have a different effect. So the reason why this is important, because when you talk about later the screening process, there may be some modifications made on the guidelines based on the agent use. and the risk of the agent being implemented. The interferon gamma down regulations is also different among different types of biological age or among different types of tumor necrosis factors. And the British Biologic Registry clearly showed that the risk of tuberculosis is really different between those agents. So they're not all the same. Now, the drugs that interfere with interleukin 12, 23, interleukin 6 do not have the same problem. And as such, a lot of these drugs, as per the available guidelines, either have a very low risk, like rituximab, and the risk is only seen in high endemic areas, or totally no risk. So again, the importance of targeting or knowing which drug you are using and what are the risk factors. Now, risk stratification. We go for some other elements on risk stratifications that would include the endemic area. So we are in at least a moderate endemic areas in Kuwait and Saudi Arabia, compared to, for example, some other parts of the world. In Sweden, for example, patient with rheumatoid arthritis will have only 2-fold increase in TB risk if treated with biological agent or tumor necrosis factor inhibitors, compared to Korea, for example, they have 9-fold increase in the risk. Now, latent tuberculosis. I think latent tuberculosis, most of the information here is diagnosed when an individual shows positive reaction to a screening test, but has no evidence of active tuberculosis. Now, the current methodologies we use is either TST or EGRA. There are some more investigational, some skin tests or some lab tests that are still evolving. They're not yet in any guidelines, but you probably may hear about them soon. Now, TST has been the standard for a very long time. Problems with TST is that it has so many proteins widely used or widely shared by many mycobacterium, including environmental mycobacterium, and BCG is also interferes with the results. So there are major problems with the TST, especially in immune-compromised patients. Some of the patients that you are giving these treatment for are immune-compromised themselves. So TST is clearly not the way to go to screen for those patients, or at least not as a sole screening tool. So we come with the interferon gamma release assay. Basically, the basic principle is that individuals infected with mycobacterium complex organism have lymphocytes in their blood that recognizes mycobacterial antigens. This recognition process involves the generation of interferon gamma, specific cytokines for cell-mediated immune response. If I can subject those cells to these antigens specifically present on mycobacterium or tuberculosis complex and not present on a lot of environmentals, and if I can pick up the gamma interferon release, then I would be able to have a more specific tool for latent tuberculosis screen. There are different preparations available: the QuantiFERON TB Gold, the QuantiFERON Tube, and the QuantiFERON Plus, and the T-Spots. They do have some differences between them, but I don't think we have time to go over this. But now, TST versus EGRA. EGRA has a better specificity than TST. TB Gold is less sensitive than the QuantiFERON in tube and T-Spot. EGRA does not cross-react with BCG. EGRA less affected by prednisolone, for example. Although T-Spot TB is superior to in predicting the probability of TB infection. This is one form of TB Gold. Now, as I said, I don't have time to go on the differences between them. I don't know which one do we have here. TB Gold? All right, because in Saudi we have the TB Gold. We don't even have, or in King Fahd, the National Guard Hospital, we use the TB Gold test. Now, let's speak about the protocols that we use to screen for those patients. If you go across the literatures, you find different protocols and different screening tools. Some people use TST alone or EGRA alone. Some people use TST and EGRA, and some people use EGRA alone. there are factors that would determine which one to use. If you are in an endemic area, definitely TST is not your best friend. If you are in an area where there is a high BCG vaccination, TST alone is also not your best friend. If you are in an area where there is, or you are using it for patients with a high exposure, TST is not your test. And if you are also dealing with the patients who's an immune compromised, probably both tests then would have some problems, but a TST would have more problems than EGRA. So you are allowed to use TST alone if you are in a low TB prevalence, no BCG, and totally intact immune system, and do not have an extra risk factors for tuberculosis. EGRA, on the other hand, can be used alone in all of these conditions. The combination tests are probably preferred by so many guidelines, because two tests are better than one. In fact, the British, or before I go to that one, what is your worst fear with the screening tool is to have a false negative test. And this is why a combination would probably eliminate the possibility of a false negative testing. Now, in the British guidelines, they use TST plus EGRA, plus also they introduce something else. They introduce the risk stratification based on age, ethnicities, and residence duration in the United Kingdom. In a sense that 3 tests would be able to eliminate any potential possibility of a false negative screening tool, and would increase your probability of preventing tuberculosis in those patients. Screening protocols. Now, what do you actually do when a patient comes to you? You have a patient planned for a biological therapy. You have to start by assessment for both latent TB and TB risk for both active and latent TB. You take a history, good clinical assessment, and do a chest X-ray. If he has an evidence of active TB, then you cannot give biological therapy yet, and you have to go into the treatment phase, and we're going to talk about that later on. If you have no evidence of active tuberculosis, but you have a past history of treatment for active or LTPI, if the answer is no, then it's a different story altogether. So let's start by the yes. Let's say there is a past history of treatment for active or latent TB. You will ask the question if there is adequate therapies being given. If the answer is yes, then you will consider giving, may give therapy with a close follow-up after doing a screening test. If he received adequate therapy, you just may give the treatment. If the answer is no, then you have to treat for latent tuberculosis. If the answer for the past history of treatment of active TB is no, but he has evidence of healed tuberculosis lesion in the chest X-ray, if the answer is yes, then you also need to consider treatment for LTPI. If the answer is no, then you do the LTPI screen, and we go to the second slide, which is similar to the previous one, and you do the TB. We start here with the TB screen. So as we said earlier, we actually encourage the use of the 2 tests rather than 1 test. And you start always by EGRA. And if you're going to end up using the 2 tests, you have to do EGRA before TST. Otherwise, EGRA may become positive if you do TST before. And you have a duration of up to 3 days, not more than that. If you end up doing an EGRA after 3 days of a TST, the results may be affected. In immune-compromised, BCG vaccinated, non-MTB high prevalence, going to be, as we said earlier, you're going to do EGRA. If the EGRA is negative, you have to do TST. If it is undetermined, you will end up also doing TST. If it is positive, you will diagnose LTPI and you need to treat. In an immune-competent person, if you are quite urgent on starting the therapy, you use EGRA and TST together. If there is no urgency, and he's an immune competent, you can't do TST alone. But as we said, a lot of guidelines are discouraging this. Few issues that you need to remember. TST alone, as we said, is not suitable. 2 steps TST is not generally recommended, except if there is a high occupational risk or a recent contact. Some of the reasons that make you feel that the false negative rate is quite high. Now we'll skip those 3 slides. In fact, this is one of the, this and the previous slide, Dr. Abdullah wanted me to sort of go into this, which is the retesting for those who are negative. Now the retesting for those who are negative will depend upon the risk of exposure. If you have somebody whose risk of exposure for tuberculosis, again, after treatment is quite low, there is no need to retest. But let's say you are a physician and you are getting the treatment for tumor necrosis factor inhibitors, your risk of re-exposure again is quite high. Then it makes a lot of sense to retest those patients who are originally negative, either with a TST or with an EGRA. And there is actually some evidence in literature to support that. Treatment regimens, you can go 9 months of INH, 3 months of INH plus rifampin, 4 months of rifampin, 3 months of INH plus rifabutin. All of these are the regimens. What type of follow-up do you do? We see them 1 month, 3 months, 6 months, 9 months, and 12 months. You can do it less frequent if the risk of re-exposure again is low. In all of them, we do history, physical examinations, and sometimes we do chest X-ray based on symptoms. Standard regimen for treatment. 1 more minute. Therapeutic issues. When can anti-tumor necrosis factor be restarted if latent TB is diagnosed? A period of 4 weeks is needed. However, there are some new data to suggest that actually earlier therapy might be allowed. For patients who develop active TB while on therapy, TNF is usually stopped. The decision to restart again should be based on the patient's characteristics. 4 to 6 weeks used to be the recommendation with a radiological resolution and sputum sterilizations. However, new data in HIV are suggesting that even earlier can be done. Risk of paradoxical worsening is important to remember when you stop anti-tumor necrosis factor, and some of those patients may require either steroid or restarting the tumor necrosis factor. This is the slide I was telling you about. Remember, it's not only tuberculosis which is important. Non-tuberculous mycobacterium is important. Hepatitis B, hepatitis C, the prophylaxis, the vaccinations are quite important. Restarting the biological agents. Thank you very much, and I apologize for the extra time.